In this video, we're going to be palpating sternocleidomastoid, which is one of our more superficial neck muscles running up the side of the neck into the head. So we're going to go through all three of its palpations for origins and then insertions. So in its name, sternocleidomastoid, one of the origins is on the sternum. So what I'm palpating is the most superior aspect of the sternum, which is actually called the manubrium, and then kind of right up towards this notch at the top of it, the suprasternal notch. So I'm going to have my partner here rotate the head slightly away from me, which is known as contralateral rotation, and slightly lift the head up off the table. And you'll see right in this area here that there's a nice tube of muscle attaching to the most superior part of that sternum, and you can relax back down. So that is known as the sternal head of sternocleidomastoid. Lateral to that is the attachment off of the clavicle, and this is, again, depending on a reference point, somewhat would say this medial third on that superior aspect. So I'm going to again ask my partner to lift their head up off the table. So kind of from the edge of that sternal attachment, you will see the clavicular attachment all along here. So a little bit deeper, it's much broader on that origin. Good. The two of those are going to run up the side of the neck. So I'm actually just going to change his neck position, making it a little bit easier for me to palpate. So I've lifted up his head. I'm doing contralateral rotation and flexion, which are two of its actions. And that just makes it a little bit easier for me to find its edges in this slack position. Now, as soon as I ask him to lift his head slightly out of my hand, it makes that muscle nicely stick up. So I'm grasping both bellies here, and I'm going to follow that all the way up towards its insertions. Right in behind the ear here is the first one, which is known as the mastoid process of the temporal bone. And you can relax your head. Good. So along here, mastoid process of this temporal bone. And then in behind that, it starts to attach to just the most lateral aspect of the superior nuchal line of the occipital bone, which is right in this area. So if we ask him to lift his head up again, you'll see this first connection going into the mastoid, but it almost slings back a little bit. And this is more our occipital bone attachment right in through here. You can see me pulling on that right there. Good. And you can relax your head back down. So that goes through our palpation of it, but I'm just going to explain some of the actions before we go on, just to make sure. So because this is running from anterior to posterior, it's going to act at different parts of the cervical spine. So in our lower cervical spine, this muscle actually causes flexion, but on the posterior aspect, it causes extension, which is known as capital extension. So we have cervical flexion and capital extension bilaterally. If this muscle is acting on one side, with that action, it's also going to cause a contralateral rotation and lateral flexion of the head. Ultimately, what you're trying to do is bring this mastoid process as close as you can towards the sternum. So that is going to conclude the actions of this muscle, and we'll check back for a manual muscle test coming up next. All right, in this video, we're going to be palpating the anterior scalene. So we're going to be palpating the right anterior scalene. So we're going to go through some counting of the origins. The anterior scalene originates on the transverse process of cervical vertebrae 3 through 6, and specifically on the anterior tubercles of those vertebrae. So as we're going to go for a count, I'm going to show you landmarking cervical vertebrae 3 and counting our way down. The method that I like to use is starting off by finding the mastoid process of the temporal bone, and then secondarily the angle of the mandible. So if I landmark both of those two landmarks, the TVP of C1 is approximately midway. Now, I need to bring his head back to neutral, so this is a step you want to make sure, so you don't have them rotated away when you do this. It's going to change the position of your cervical spine. I want to be in between, and I also want to try to get, in this case, anterior to the sternocleidomastoid. Since SCM is going into the mastoid process, and this landmark is anterior to that, I want to make sure that I can almost push back on SCM when I go looking for it. Sink in gently. This area is often very sensitive for an individual, so I found the TVP of C1. Now, it's approximately a finger pad width down. The TVP of C2 is actually mid-belly to sternocleidomastoid. So we want to move that SCM up out of the way now and sink in a little bit until you find the bony object of the TVP. Again, I'm going to walk down. So here's our first one. Transverse process of cervical 3, 4, 5, and 6. So TVP, cervical 3 through 6. When it comes to the anterior tubercle part of the TVP, if you pushed into the transverse process here, we're just going to roll our fingers towards the front of the neck or anteriorly, and that would show us getting closer towards those anterior tubercles. Exiting out in between the anterior middle scalene, for food for thought kind of, is the brachial plexus. So when we push into the side of the neck, we want to roll towards the front of this muscle belly and make sure we're not on the nerves itself. And one of the actions that the anterior scalene does, and actually all three of the scalenes do as a group, is lateral flexion. So what I like to use is the side of my finger and run it down along the edge here and get my partner just to push into the side of my hand with their head. Good, and relax. So I can feel that contraction of SCM. The other thing to note is that I'm lifting up the lateral edge of his SCM to find anterior scalene. So if I asked him to lift his head gently up with my hand, you will see sternocleidomastoid push my finger over, and when he relaxes, I drop back down on top of the anterior scalene. So this is the belly of anterior scalene, and we're going to follow it down. The actions of this anterior scalene, one was lateral flexion. The second is going to be flexion of the neck, and due to its origin to insertion, it also does a slight contralateral rotation. But we're going to focus mainly on that lateral flexion. To get towards its insertion, which is what is known as the scalene tubercle of rib 1, I'm going to soften up his neck by laterally flexing towards the side I'm palpating on and sink in behind the clavicle and underneath the clavicular head of sternocleidomastoid. As I sink down towards this location, again, we're very, very close to the neurovascular bundle of the thoracic outlet, so you want to be cautious not to be causing any numbness and not feel pulse in this area. To confirm that I'm on the scalene tubercle, I'm going to ask my partner to take a nice deep breath in, and as he breathes in, that rib 1 is going to elevate, so I can feel the bony rib pushing up into my finger when I'm on it. So another one of the actions of the anterior scalene is to elevate rib number 1. So we've palpated starting from the origin, down along the belly, and then sinking in towards that insertion on rib number 1. So that's going to conclude our palpation of the anterior scalene. All right, in this video, we're going to be palpating the middle scalene. So I'm just going to be picking up his head and slightly rotating it away from me. So I'm going to go through the origin, which is on the transverse process of cervical vertebra number 2 through number 7. So again, I'm going to show you how to landmark the transverse processes. If you've watched the anterior scalene, you've already heard this, but what I'm basically going to do is start off by landmarking the mastoid process, as well as the angle of the mandible, splitting the difference and trying to sink in, and I should be in front of the sternocleidomastoid. So when I'm sinking in here, I'm looking for a bony object, which is the transverse process of cervical vertebra number 1. So I've landmarked that right here. The middle scalene is starting on number 2, TVP of number 2, so I'm going to go about a finger pad width lower and push the scalene up out of the way, and now I've landmarked the transverse process of cervical 2. Now, unlike the anterior scalene, the middle and then posterior scalene are actually originating on the posterior tubercles of the transverse process of cervical 2 to 7. So instead of rolling forward like I would for the anterior scalene, I'm actually going to stay and slightly more posterior. So I found 2, I'm going to just walk down 3, 4, 5, 6, And finally 7. So the transverse process of cervical 7 is right at the base of the neck. It might be a little bit lower than where you see trapezius, but obviously it's going to be above the clavicle in here. So there's the transverse process of cervical 7. So this muscle has quite a few attachments running all the way down the side of the neck. And for its insertion, it's going to be down on rib number 1 again, just more posterior than our anterior scalene. So to palpate the muscle belly activating, the scalenes primarily do lateral flexion. So again, I'm taking the side of my index finger here. I'm going up against the side of the neck, right over top of those transverse processes. And I'm going to ask him to push his head into the side of my hand. Good. And right here, I can easily feel a roll of muscle belly. It feels quite tight. I'm going to follow that down. And as I get closer towards that rib number 1, I'm going to laterally flex his neck towards me, softening up that space, making it easier for me to sink down towards rib number 1. Now, exiting out between the anterior middle scalene is the brachial plexus, as well as the subclavian artery. So be very, very cautious about pushing too hard in here, because you might cause some numbness and tingling, or you might feel the pulse. So I can feel the pulse in this location, and I'm just more posterior to that, and I can feel the roll of what I believe is the middle scalene. So I'm going to confirm that by asking him to take a nice deep, deep breath in. As he does that deep breath in, right underneath my finger, I feel rib number 1 elevating and the scalene tightening up. So that's confirming that I found the insertion. So we had anterior scalene on that scalene tubercle, then our brachial plexus, and this is also to rib 1, just a little bit more towards the posterior aspect of it. And that's going to conclude our palpation of the middle scalene. All right, in this video, we're going to be palpating the posterior scalene. I'm going to start by picking up his head in one hand, bring it off to the side. The posterior scalene originates from the transverse processes of cervical vertebrae 5, 6, and 7. But I still need to count my way down the transverse processes, so I'm still going to start from the top. As seen in previous videos, I landmark the mastoid process as well as the angle of his mandible and go part way in the middle. I am anterior to the sternocleidomastoid as I sink in and try to find the transverse process of C1. The transverse process of C2 is going to be underneath sternocleidomastoid, so I move it up out of the way to find the TVP of 2. And I'm going to count my way down 3, 4, 5. So this is the beginning of posterior scalene. It's on the transverse process, and again, like the middle scalene on the posterior tubercles. So this is 5, 6, and 7. And again, 7 is right down at the base of the neck in front of the trapezius. You just feel a little bit of a projection sticking off to the side. So this muscle is on a different fiber direction from the anterior middle scalene. It does not run straight down because it's actually going to rib number 2. I'm going to turn my finger kind of on an angle, so the muscle is more running like this. So our fiber direction is going to look a little bit different from the other scalenes. Because it is a low origin on the cervical spine, it's really only going to have an effect on the lower C-spine, plus then on the elevation of rib 2. I'm still going to use lateral flexion though to try and confirm it. So I believe I found a little bit of a roll of muscle belly in the correct location. But I'm going to place my hand up against the base of his head here and ask him to laterally flex into me. Good. And right in here, I've definitely started to feel that posterior scalene. You're not going to be able to feel all the way down towards rib 2. That is too deep. But I'm still going to laterally flex and sink as far as I can. With that deep inhalation that we've done in the previous scalene videos, go ahead and take a nice deep breath in. The posterior scalene is going to tighten up as it elevates rib 2 as its opposite action. Again, you will not be able to go all the way down to rib 2, but this is as close as I'm going to get for it. So the actions for the posterior scalene are just going to be lateral flexion of the lower C-spine, and then again that elevation of rib 2 during deep breathing. In this video, we're going to be palpating levator scapula. So we're going to go through the origins of levator scapula. Levator is originating on the transverse process of cervical vertebrae 1 through 4. So I'm going to be counting those TVPs. I prefer to treat and palpate in a supine position, so that's why I'm palpating this muscle in this position today. You're finding the mastoid process here, as well as the angle of the mandible, something we've landmarked for TVPs in other videos. And I'm going to be anterior to sternocleidomastoid. I'm going to sink in, I'm going to gently go up and down here, and I'm feeling a little bony nodule sticking out to the side. This is the TVP of C1. Now, the majority of this attachment is just tendinous, even though I'm still going to ask my partner to try to confirm that I'm on it using an elevation of his shoulder. Good, so he's elevating a little bit. Again, I'm not feeling a whole lot here because, again, like I said, it's tendinous and not muscle belly yet, but I'm just trying to confirm that TVP of C1. TVP of C2 is going to be mid-belly sternocleidomastoid, so I'm going to push it up out of the way and sink in to feel that. I'm going to go down a little bit, TVP of C3, and then the TVP of C4. So this muscle belly is behind the middle scalene in the upper attachment in here. So what I'm going to ask him to do is the prime action of levator scapula, and that is elevation of the scapula. We have to be very careful of with this is the secondary actions that's occurring with the scapula is called upward and downward rotation. Now, upper trapezius is an upward rotator of the scapula. So if he was trying to bring his acromion towards his ear, that would be adding an upward rotation. But levator is actually more of a downward rotator. So the scapula is already in downward rotation. So as he elevates it, he wants to try to lift it straight up without bringing that acromion too close to the ear. So that's excellent right there. So I'm going to tuck into the side of the neck here, and I'm going to ask for that action. Good. And relax. Now, it also is a lateral flexor of the neck, but again, I'm trying to differentiate it away from the middle scalene, and the scalenes are your primary lateral flexors. So I'm going to stick with the elevation of the scapula instead. Now, a lot of people's levator scapulas are really tight, so I'm easily able to follow the ropiness of this muscle as I'm heading down towards its insertion. Now, there's a little bit of argument about exact insertion of levator scapula, but we're going to say both from what I've seen in a lot of literature. Some individuals will call this the superior angle of the scapula, right in this location, and others say it's on the superior medial border of the scapula above the root of the spine of the scap. It's basically the same location, and all they're kind of saying difference is, does it go across the whole superior angle, or is it just on the medial side of the superior angle? If you're unable to feel the superior angle right in this location, then we can also move the scapula a little bit to get a bigger view. So what I like to teach is that you should look behind the clavicle, you should look anterior to trapezius and lateral to the neck. So I've created a triangle here, and it's towards the back of that triangle. You can ask your person to try and lift that scapula up towards their neck. Good. You'll feel the bony object. Or the secondary way to do this is to manually lift up the scapula. So what I'm going to do, and my partner already is aware of this, I'm going to reach underneath and I'm going to cup the inferior angle of his scapula with my fingertips, in this case of my left hand. Once I've grabbed that, I'm going to passively lift his scapula up towards me, which elevates it, and it makes it easier for me to feel the superior angle. So again, if you're able to elevate that scapula up for me, good, and I can feel it easily right away without having to sink too far into his neck here. Levator has quite a complex amount of movements, so I'm just going to explain a bunch of them just to make sure towards the end of this video. So it elevates that scapula and keeps it in a downward rotated position. It has minor capability to almost retract it a little bit, but then with the neck, it's going to be laterally flexing to the side, And again, because the origin is on the transverse process and the scapula is a little bit more towards the back, it's going to cause ipsilateral rotation and a minor amount of extension towards that side. We're going to go through all of those actions in another video for the manual muscle test and length. So for now, that's going to conclude our palpation of levator scapula. All right, in this video, we're going to be palpating the upper trapezius. So we're going to be starting on the origin of upper trapezius, and I'm on his occipital bone currently right now. And if you palpate up into the back of the hairline here, you usually come across a fairly large bump. This is known as your external occipital protuberance, short form to EOP of the occipital bone. And then just off lateral to it, you should feel a bony ridge. So this is known as your superior nuchal line of the occipital bone. So trapezius attaches to the EOP and the medial third of that superior nuchal line of the occipital bone. The next attachment is actually soft tissue, and this is known as the nuchal ligament. So as I start to palpate distal from the EOP, and we're heading towards the cervical spine here, you will not typically be able to palpate it, but it's this connective tissue ligamentous band that runs all the way down towards cervical 7. So the nuchal ligament is a soft tissue attachment for upper traps. As I count my way down here, I'm basically palpating all of the spinous process of a cervical just to make sure that I end up on cervical spine number 7. So the transverse spinous process, of cervical 2 is going to be the first one that we come across. So that is right in here. Since C1 does not have a spinous process, I'm going to count down and find 3, 4, 5, 6, and then 7. So the spinous process of cervical 7 is also known as the cervical prominence, since it is the largest spinous process of a cervical spine. Now, to confirm that I'm on cervical 7, what I'm going to be doing is placing one finger pad on what I believe is the spinous process of cervical 7, and one finger pad on the vertebrae below that, which is, I'm hoping, is thoracic 1. Cervical 7 should have more mobility from it, since thoracic 1 has ribs attached to it by way of the vertebrae. So what I'm going to do is I'm going to rotate his head in the cradle, and what I'm feeling underneath that index finger is that basically the spinous process is rotating back and forth. So therefore confirming that this is cervical number 7. So again, the origin of upper trapezius is the external occipital protuberance and superior nuchal line of the occipital bone, the nuchal ligament or ligamentum nuchae, and the spinous process of cervical 7. The muscle fibers are going to run out lateral, folding up on themselves and attaching, first of all, here along that superior lateral third of the clavicle. And then as we go a little bit more lateral than that, on the acromion process of the scapula. So I'm going to ask my partner just to elevate his shoulder, good, as I'm palpating and separating that trapezius muscle. And we can follow that all the way out to its 2 insertions. Now I'm going to follow that back up. So I'm scooping and lifting it up a little bit, plus using my thumb to help separate upper and middle traps. And I'm going to round this corner and follow it right back up towards the occipital bone. Now trapezius often gets a little too much credit in the back of the neck. So what I'm going to do is I'm going to show you a bilateral. So I'm going to cut both sides here. And as I fold my fingers in, this is about the width of trapezius into the back of the neck. So it's only about an inch, inch and a half wide. The actions for upper trapezius are twofold, on the scapula as well as on the head. So for the scapula, it's going to be elevation as well as upward rotation and a retraction motion. So if you're able to bring this acromion all the way up towards your ear for me, good, and then back down. And then on the head, we're going to try to bring our external occipital protuberance towards the acromion. So that would do some contralateral rotation, some extension of both head and neck, as well as lateral flexion towards the side, making this somewhat of a complicated full action for this muscle. Excellent. So that's going to conclude our palpation of upper trapezius. All right, in this video we're going to be palpating the middle trapezius. So middle trapezius is originating on the spinous process of thoracic vertebrae 1 towards 5, and I'm just guesstimating right now, but we're actually going to go through our palpation. So what I'm going to be looking for to start is where the cervical prominence, which is also known as the spinous process of cervical vertebrae number 7. So I'm palpating for one of the more obvious 1 or 2 vertebrae in the back of the neck here and upper back. I believe I've found cervical 7, so I'm going to place one finger pad on thoracic 1 spinous process and one on cervical 7, and I'm just going to gently rotate my partner's head in the cradle, and again I'm feeling more movement coming out of the index finger, indicating that this is most likely cervical 7 and this is thoracic 1. So from here I'm going to count down towards spinous process of thoracic 5. So 1, 2, 3, 4, and 5. So this is the origin on the lateral aspect or side of the spinous process of thoracic 1 to 5. And our fiber direction is going to be running lateral and slightly superior. So I'm going to try to almost leave a little bit of a red mark on our body here just to make it a little bit easier for us to follow. So our fiber direction runs this way, and as it heads towards the scapula, it starts attaching here along the spine. So it attaches all along the spine of the scapula and finally to the acromion process. Our upper attachments will go all the way out towards the acromion, and our lower attachments are the ones that are mainly going into more of the spine of the scapula. So I'm giving you an approximate of what it might look like. So now we're going to activate this muscle and prove it. So I'm coming over to the side. I'm just going to be bringing his arm off the table. And what that's actually doing is bringing the scapula a little bit more into an upward rotated position. The next thing that I'm going to do is I'm going to have him bring his arm out at the side, and I'm going to have him externally rotate this humerus and then change the position of his scapula a little bit. So I'll do that once or twice to make sure you guys can see that. So this is more of a relaxed position. And as we get into that external rotation, the scapula does a little bit more upward rotation to allow for it. So what we like to say is that the thumb is facing up towards the ceiling. So he's going to hold his whole upper extremity up off the table for me. And what you can see right in this area is this is upper trapezius. I'm kind of covering with my thumb and my hand, but right in here is the middle trapezius. So my partner is just going up and down with his arm a little bit, and so you should be able to see that. Now let's have him drop his arm to the table, and now he's going to lift that up nice and slow on his own. There we go. You can see those fibers moving. So right in here is the middle trapezius. Its primary action is not on the humerus itself, but it's actually bringing the scapula towards the vertebrae, which is known as retraction. So upper trapezius, as well as middle and lower, all act slightly to do with upward rotation, but the primary action of our middle trapezius here is just retraction of the scapulothoracic joint. Excellent. So that's going to conclude our palpation of middle traps. We're going to be palpating in this video the lower trapezius. So what I'm going to be doing is actually starting by palpating the lower attachment, which is the spinous process of thoracic 12. Now again, I'm just guesstimating, but what I'm going to be using is actually his rib 12 to try and help us landmark where that spinous process of 12 is. So I'm going to reach across, and again, I'm going to try to sink into this softer location here, which is above the iliac crest of the ilium, and landmarking where that rib 12 is. So once I'm able to find rib 12, it's the lowest rib. We have 12 ribs on that one side. I'm going to gently go back and forth across it and follow it as central or medial as I can. Now, ultimately, you're going to lose it as it goes underneath the erector tissue around Iliocostalis here. But I'm going to just generalize that the rib is heading in this direction towards the thoracic spine. The rib is going into the body of the T-spine, and we're not looking for that. However, again, the vertebrae is going to sit pretty much central here. So what I'm going to look for next, I believe I found the SP of T12 using that rib, is the size of it. So I'm going on the above and below that spinous process of T12 here. And if I went to the next segment, you can see it's actually quite a bit larger. So this is the SP or spinous process of lumbar 1 versus that's the spinous process of thoracic 12. So an indicator is the size of the spinous process. So now that I've found thoracic 12, I'm going to count my way up towards 6. So 12, 11, 10, 9, 8, 7, and 6. So I've left a couple fingers on 12 just so I can show you the whole lower kind of origin here. And our insertion is higher than that. So our fibers are going to run up towards the scapula, and they're going to be attaching to what is known as the tubercle of the spine of the scapula. So what I'm going to do is I'm palpating along the scapula looking for the spine. I've landmarked it. The most medial part of that spine is known as the root, and just a little bit lateral to that is known as its tubercle. It's a thickening on the spine. So I'm going to draw an imaginary line for us to kind of see going from thoracic 12 towards the root. So my partner knows this is coming, but I'm basically just going to draw an imaginary red line. It'll be easier for you guys to see on camera. So that's kind of showing our muscular edge. So what I'm going to then do is just try to show you that if you palpate along that edge, you'll actually be able to see a little bit of a muscle belly sticking up. Okay, so we're going to get into activate the muscle and how to prove that that's the approximate location. So what I'm going to do is I'm going to bring his arm off the side of the table. He's actually going to reach it out in front of him. So what we've done in this is our scapula, to achieve that flexion, is going to be upwardly rotated. And as he brings his arm up, the scapula is actually going down. So in a relaxed position, it is superior. And as we elevate it up here, it's going inferior. However, in the scapula, it's called retraction and depression. So retraction is the movement of it going towards the spine, and depression as it's moving inferiorly towards its origin. So if we look back at our little red line that I made here, as he does that action, right here is actually his lower trapezius. I'm actually going to come around to the side here, just chase the camera a little bit. So as he relaxes his arm back down, I have my fingers along that whole border. I'm going to push over, and as he starts to bring his arm up, we can easily see that lower trap pushing my fingers. There's also a slight indentation over here on his scapula, which is actually our insertion. So you can see how this muscle is making its insertion basically right here. So that's a good telltale sign of its insertion. So watch my two fingers here as he brings his arm up. My upper finger is approaching my bottom finger, so that is our retraction as well as depression in a upwardly rotated position. That is going to conclude our palpation of lower trapezius. We're going to be palpating rhomboid major and minor. So I'm going to start off by finding the spinous process of cervical 7. So instead of counting all the way down, I'm going to be looking for the cervical prominence in the back of the neck. Cervical number 7, spinous process, and thoracic 1 are often the two spinous process that push out the most. Once I've landmarked what I believe to be that cervical 7 and thoracic 1, I often place 2 fingertips over top of each one and passively rotate the neck, and I can feel underneath my index finger here, this vertebrae is moving a little bit more, which is helping me indicate that this is the cervical 7. So our muscle rhomboid minor is going to be originating off the spinous process of cervical 7 and thoracic 1. So I'm going to put 2 fingers indicating those two. And then rhomboid major is going to be originating off thoracic 2, 3, 4, and 5. So you basically have 2 parts minor and 4 parts rhomboid major. So our origin for rhomboid major and minor are along here on the spinous processes, and not on the most external part, more on the lateral aspect, kind of towards the lamina on the spinous processes. The muscle fibers are going to run inferior and lateral, like so. And the beginning of the fibers for minor are going to be attaching at what is called the root of the spine of the scapula, which is basically where our medial border meets the spine. So the beginning of that spine of the scapula, some texts will also call this the medial angle of the scapula. So rhomboid minor travels this direction. And then from that root all the way down to the inferior angle is the attachment for rhomboid major. So again, from thoracic 2 to 5, towards the root all the way down to the inferior angle, making this a much wider muscle for rhomboid major. In some cases, you can cross fiber right away if that individual has a tight rhomboid. So on our body's case right now, I can feel quite a few strands running in this direction, so I'm cross fibering, but otherwise I'm going to ask for a small amount of scapular retraction. Good. So what he's done basically is he's elevated his scapula up off the table, just clearing the shoulder off the table. You don't want an extremely tight contraction, because then obviously you're going to get covered up by trapezius as well. You will feel trapezius contract with this, however, just starting to engage that muscle, good. I'm feeling those deeper fibers tighten up. Thing to remember that our lower trapezius fibers are running in this direction versus the rhomboid fibers, which are deep to them, are almost running exactly opposite. So you will be able to cross fiber rhomboids while you're going with the fiber direction of trapezius, which may help you differentiate which fibers are which. Lastly, discussing kind of the actions of rhomboid major and minor. They work as a group, and so again, because of our fiber direction, their primary action is going to be retraction, bringing this together, but because they slightly go from superior to inferior, there's also a little bit of elevation, and because they're trying to bring this medial border closer to the spine, they actually end up doing an amount of downward rotation. So those 3 actions are going to be elevation, retraction, and downward rotation of the scapulothoracic joint. That's going to be concluding our palpation of rhomboids. All right, this video is for the palpation of Latissimus Dorsi. Lats, as its short form known, is a very large muscle that's covering a large portion of the back with its origin and then going up along the side and entering into the arm for its final insertion point. So I'm going to be going through a large number of origins here, starting at the bottom. One of Lats's first origins is going to be the posterior iliac crest of the ilium, which is what I'm finding along here. And as it then goes more central, the next attachment is often references the sacral crests, which are running up and down in this area. So iliac crest onto sacral crest. From the sacrum, I'm going to go up and find the spinous process of lumbar number 5 and count my way up through all the lumbar, 4, 2, and 1, and then all the way up towards thoracic 7. 10, 9, 8, and 7. As a good visual check, and it also may include this sometimes, the inferior angle of the scapula is sometimes an attachment for your latissimus dorsi. And as a quick palp note, oftentimes our inferior angle is close to the spinous process of thoracic 7. So I feel pretty comfortable with that palpation. I'm going to palpate a very broad surface in here because a large amount of latissimus dorsi is actually attached to what is known as the thoracolumbar fascia, which means a lot of our muscle belly isn't starting till it's in the ribs here, and a lot of this is just more of a connective tissue attachment. So as we go then down, the next origin is going to be along the inferior 4 ribs, which means I'm landmarking currently right now his rib number 12, a little bit up from that, rib number 11, rib number 10, and rib number 9. And at this point, we have more of a muscular fiber to bone attachment. So I'm going to bring his arm slightly away from his body. I'm going to ask for him to try and push his whole arm up in towards my hand. Good. So what he's basically doing is trying to do some extension, as well as I'm resisting a little bit of medial rotation. So again, I'm going to push down on that, and I'm going to try to cover a large surface area through the side of his back. Now, this next part, I'm going to be bringing his arm off the table, and I'm going to be reaching down with one hand, resisting a medial rotation and extension, and with my other hand, I'm going to be following up towards his axilla. So he's going to go ahead and resist into me. So now I can feel the edge of that lat. You should actually be able to see me pulling up on it here. And as it makes its way up towards our axilla, and you're going to relax for me, it gets very, very close to a muscle with similar actions known as teres major. So again, I'm going to reach down, add some little bit of resistance. So right here, I'm pincher grasping his latissimus dorsi, but just above my finger, my thumb I should correct, is actually teres major. So make sure that you're going up towards the axilla, you're not grabbing both teres major and lats, that you're sticking more anterior to teres major. We're going to follow that muscle right up into the axilla. At this point, I'm actually going to bring his arm into quite a bit of medial rotation, and I'm going to sink into the axilla and up towards its insertion. Now, latissimus dorsi is not going to be an easy insertion for you to palpate directly from this position, since it's inserting into the floor of the bicipital groove, and to get there, it's got to pass by the brachial plexus as well as your brachial artery, underneath coracobrachialis and biceps, and finally to that bicipital groove. So you're going to do your best, and I'm going to get him to push up in the medial rotation to try to follow it until it starts to dive down underneath. Another option, it's going to be a little bit tricky on the camera, is I'm going to reach to the front of his arm. So I'm underneath, and I'm going to cross fiber his biceps tendon here. When I find that long head biceps tendon, which I have right now, that's in the bicipital groove, I'm going to immediately rotate his arm and show you that my fingertips are on his biceps tendon here. So lats is making its way towards those fingertips, but it has to go underneath coracobrachialis. So you won't be able to follow it all the way through. So that's going to conclude our palpation of latissimus dorsi from a prone position only. All right, in this video, we're going to be palpating pectoralis major, and I'm going to be palpating 3 heads of pectoralis major. Now, this may be contrary to some texts. However, I'm going to be going through 3 manual muscle tests in 3 length positions, so I'd like to go through pectoralis majors having 3 heads. So we're going to be talking about the clavicular head, we'll be talking about the sternal head, and down towards the bottom we have the abdominal head. So I'm going to start off with pectoralis majors origins. So I'm going to start by having my partner bring their arm out to the side and then hold their arm up in the air a little bit. So you can already see the beginning attachment here of his clavicular head of pectoralis major, which is attaching to the medial half or so of the clavicle, which I'm running along. And then there's usually a bit of an indentation here or fascial separation before it starts attaching to its sternal head. So I have him resisting a little bit of flexion and adduction, so he can push up into me, and again, you can get a little bit more of that fiber definition. The second attachment is going to be along the sternal head. So there's 2 parts to this. One, it goes all the way down the body of the sternum, as well as a little bit of the manubrium up here at the top. And then second to that, it attaches to the costal cartilages of ribs 1 through 7. So I'm just going to count that out. Here's the clavicle, directly underneath it, costal cartilage of rib 1. Below that, costal cartilage of rib 2, in line with the sternal angle here. Costal cartilage of 3, 4, 5, and then 6 and 7 often start to blend together. So I'm going to switch, leaving my fingers on 5, and I'm going to walk up the bottom costal cartilage, which is 7, and that meets at the xiphoid process here, and 6 and 7 often blend together. So it might get extremely tricky to try and feel the differences between 6 and 7 costal cartilage at the sternum. So we have an attachment all the way down along the center here, and then that costal cartilage of 5, 6, and 7 blends out into what some refer to as the abdominal attachment, which goes into the abdominal aponeurosis. So abdominal aponeurosis is a covering over top of your abdominal muscles and an attachment for your obliques. So if we bring the arm up above the head, I'm going to ask my partner to try to bring his arm down and across, giving him some resistance here. We can see a tightening up happening through this lower edge of pec. And then if he was to do a little bit of a crunch for us at the same time, good, engaging the abdominal muscles, that makes a connection into our pectoralis major fibers. So we have origin, origin, and origin. All of these fibers are going to be running lateral, and in some cases superior, towards the lateral lip of the bicipital groove of our humerus. So again, I'm going to have him hold his arm up in the air, and I'm going to be using a pincher grasp to try to grasp as much of that belly as I can, sticking my thumb up in the axilla. I'm going to switch my hands here just for effect so I can lengthen the muscle out, and I'm going to follow that all the way up until it inserts on our humerus. He's going to relax his arm down, and I can strum back and forth right at that attachment, and you will typically feel the long head of the biceps tendon. So our pectoralis major is going just over top of that long head, inserting on that lateral lip of the bicipital groove, or otherwise known as intertubercular sulcus of the humerus here. It's quite a wide attachment. So again, you can see the lowest part here and the upper part there, making this almost a couple inches long. So pectoralis major has quite a few fibers. We're just going to review them quickly towards the end here. For our clavicular fibers, it's going to be doing some flexion, medial rotation, and adduction, or horizontal adduction, if you'd like to call it that. The sternal fibers primarily do horizontal adduction or flexion, bringing the arm straight across the body. And our lower fibers or abdominal fibers are going to bring the arm from a flexed position into an extended position, but also medially rotate and adduct. So we're going to be using those actions coming up in the manual muscle test video. That's going to conclude our palpation of pectoralis major. We are going to be palpating pectoralis major. So So we're going to be navigating around chest tissue in this. We're going to be starting off with the insertion of pectoralis major, which is on the lateral lip of the bicipital groove. So I'm just going to grab her arm here, bring it out. I'm looking at the most anterior and proximal aspect of the humerus. I'm going to use an internal and external rotation and try to identify where this biceps tendon is. This is the long head running up through the bicipital groove. Pectoralis major is going to the lateral lip of this bicipital groove, otherwise called intertubercular sulcus. I'm going to have her just lift her own arm up off the table for a moment here, and right away I'm starting to feel this tendinous insertion point into that bicipital groove. She can bring her arm down. Now, pectoralis major has some interesting quality because of how large it is. So you have some clavicular fibers that are running in this direction, but you have underneath some abdominal fibers that are running up. So it almost feels like it folds over top of itself. So you might feel quite a thick band towards the bottom, but there's also tendon running all the way up. So our insertion is quite large in comparison to other muscles. This is a very large mover of your upper extremity. So I'm just grabbing that whole musculotendinous kind of attachment here going into our insertion. So we will be breaking this up into 3 components. So we have a clavicular fiber, we're going to have our sternal fiber, and then we're going to go through and discuss what I call the abdominal fibers, which help us perform 3 major kind of movements of horizontal adduction. So the arm is going to be coming up in a flexion motion, going across the body like so, in that horizontal adduction. We can bring it into a straight horizontal adduction, which brings it across the body like so. And if the arm is above the head, it produces extension from this flex position, almost like you're touching your opposite hip. So this upward motion here is a big, large component of the clavicular head. The straight across is going to be more from the sternal head, going towards the sternum, and then this downward motion from more what I call the abdominal head. So we're going to be going through the origins now, since that was the insertion, and the first aspect is going to be up here on the clavicle. Is it okay if I move your strap just to the side a little bit? So I'm just going to pull this over just so it's a little bit easier for us to see. I'm going to again have her hold her arm up in the air, and right away I can start to feel that edge along this clavicle. So it's attaching to that anterior and inferior part of the clavicle as it runs its way all the way along towards the sternum. Now, if you are working in and around chest and breast tissue, what you might ask your partner to do is take their opposite hand and just push down on breast tissue, and therefore you're able to get a little bit more palpation. So I'm working my way. So again, here is our clavicular aspect of it. If the arm is brought up across the body, I'm going to give her a little bit of resistance this time. So you can feel the head is about this wide, and again, it's going to make its way over towards a little bit more on the inferior part of that insertion point in here. Okay, the second part of this, the sternal head is going to be running down the sternum as well as attaching to the costal cartilages of ribs 1 through 7. So for this, we're going to again ask our individual here to create a border for us. So she's going to be reaching inside and kind of pushing breast tissue laterally, which kind of opens up the proximal part of the chest here. So as I find the medial end of the clavicle at that sternoclavicular joint, I'm going to drop just below that, and this is going to be the costal cartilage of rib number 1. I feel a little interosseous space. We have rib number 2, interosseous space, rib number 3, and I'm not going to go any lower at the moment until I ask her to readjust her border. So at the top here we have our manubrium, and we have the body of the sternum. I'm going to ask her to go a little bit lower with her bordering and lift up into the side a little bit. Thank you very much. And this time I'm going to approach from the bottom. So the lowest cartilage to attach to the sternum is costal cartilage of rib number 7. So as I follow this kind of softness of the abdomen up, the costal cartilage of rib 7 is going to meet on both sides near the xiphoid process, marking the bottom of the sternum. So I know that this right here is the costal cartilage of rib number 7, and just above that is going to be rib number 6, and above that is going to be rib number 5. So again, pectoralis major is attaching to all costal cartilages along the sternum from 1 down to 7. And then it's going to work its way lateral. So for this instance, we're going to again adjust our bordering one more time. She's going to scoop breast tissue up with the opposite arm. I'm going to bring this arm up. So this again was producing a downward motion like so. And I'm just going to rest my hand below her hand border. I'm going to give her a little bit of resistance on her arm, and therefore I can start to feel this abdominal aponeurosis, as well as follow the muscle lateral along the costal cartilage of 6 and 7. You can then start to go up and feel that outer edge of the pec, and I'm going to work my way back up towards the axilla and the armpit, staying lateral to her hand. And again, this is the under part of it, so you have that clavicular head over top, and the abdominal part is going up underneath, a little bit higher towards the superior aspect of its insertion. So we've worked our way all the way around all attachments of that, as well as found the insertion of that. And I'm just going to show you one more quick way to pick it up. Again, I'm going to ask her to push down on her breast tissue with the opposite hand. Using a scooping motion, you want to try to find the outer edge here. So you're either going to go up underneath. I might put my thumb inside. I'm going to shorten it, and then I'm able to kind of pick up and lift this pectoralis major. So that gives me access if I needed to lift this, and I can also easily follow it right to its insertion point. Okay, that's going to conclude our palpation of pectoralis major. In this video, we're going to be palpating pectoralis minor. Pectoralis minor is a muscle in the anterior chest area here. So we're going to be going through its O and its I, and then palpating the muscle belly. One, I'm going to be palpating the muscle belly through pectoralis major, and secondarily, we're going to be going underneath pectoralis major. The origin of pectoralis minor is on ribs 3, 4, and 5. So I like to start off of the sternum on the costal cartilages, and then work my way over towards the rib. So costal cartilage of number 1, number 2, and number 3. Once I've found costal cartilage of rib 3, I usually follow that lateral, and then it turns more into a rib from costal cartilage, and you're not really easily going to be able to feel that junction. So if you were to palpate through, the fiber direction is running primarily superior inferior, so you have to go through your pectoralis major fibers and palpating down. Now, male or female, we're not going to be making contact with the areola, so I'm not going to be heading down towards the attachment on rib number 5. You are following the belly up, and at this point, what I'm actually going to ask my partner to do is to roll his shoulder forward and down a little bit. So not excessively, and I'm going to bring it back, but almost just pushing straight up to my head. Perfect, no more than that. And go back down. So I'm going to palpate what I believe is pec minor, and again, a little bit of that action for me. Good. And I can follow that all the way up towards the inferior portion of the coracoid process of the scapula here. So ribs 3, 4, and 5, all the way up towards that coracoid process. Now I'm going to redo that palpation, except I'm going to be going underneath his pectoralis major for more of a direct palpation of pec minor. So costal cartilage of 1, 2, and 3. Again, I'm going to palpate lateral, and now I'm going to pause here. Pec major is tight usually and flat across the body, so I'm going to try to move it out of the way by using his arm. So I'm going to take his arm, keeping an idea of where rib number 3 is. I'm actually going to bring it across his body, and at this point, we're going to have it rested. So that has shortened up his pectoralis major. So I can move past it, and I can actually now go underneath it quite easily. And now I'm on rib number 3, and I can cross fiber right in here, his pec minor. I might be able to get a little of a twang on the camera for you. There we go. So here's rib number 3, underneath that, rib number 4, and then deep to that rib number 5. So we can palpate that fiber. At this point, I'm going to put my hand on top of his elbow and ask him just to push his elbow up towards the ceiling a little bit, which is protraction. Good. This time, can you push a little bit down towards my hand? There we go. So there's pec minor, lifted up in my hand. And I'm going to follow that right up into the axilla. I'm going to turn my hand and I'm going to sink in and gently work my up. And I'm now touching his coracoid process from underneath his pectoralis major. Again, very gently lift your perfect and back down. So I've palpated the whole muscle belly from origin to insertion more directly instead of going through pec major. All right, so that's going to conclude our palpation of pectoralis minor. Then we'll return for the actions in another video for the manual muscle test. We're going to be palpating the muscle pectoralis minor. So obviously our partner here is in supine, and I'm going to be showing you the insertion first and then going towards our origin. The origin of pectoralis minor, if you wouldn't mind just holding this off to the side for me for just a second, awesome, is going to be the coracoid process. So right here in the middle of the clavicle, I have the attachment of pectoralis major, and then on this portion here, I have the deltoid. So this is a really good starting spot for me to try to locate the coracoid. Now it's not in this soft space right here, it's just lateral to it. So right here, I'm doing a full circle around her coracoid process. So this is going to be the insertion of pectoralis minor, and therefore this is going to be pulled forward and down towards the ribs. So again, the insertion, coracoid process of the scapula, and then our origin is going to be down towards ribs 3, 4, and 5. Okay, you can let go of this here. What I'm going to ask you to do next is to take the top of your hand and push down on breast tissue. And what I'm going to be doing is finding rib number 2, but then from there finding rib number 3. So starting at the clavicle where it's easy and safe, I'm going to find costal cartilage of rib 1, down towards that sternal angle and the costal cartilage of rib 2, and then I'm going to start to work my way lateral. Now this rib does not go straight out, it starts to loop backwards towards your thoracic spine. So right in this area, I'm still on rib number 2. I'm then going to drop down above her bordering hand onto rib number 3. However, the muscle is underneath pectoralis major, pec minor is deep to it, so I need to get underneath the pec major. So what I'm going to do is start to bring her arm out to the side. I'm going to ask her just to hold her arm here for a moment, and what I want to do is find the lateral edge of pec major, and I'm going to go underneath pec major into the very similar location on the rib, and then I want to slacken the pec major by doing some passive horizontal adduction here. So as I have moved, you can even see pec major tightens up, and as if you bring it across your body, it slackens it, making it easier for me to push underneath. So I have rib number 3 right here. I'm going to drop down onto rib number 4, but I am not going to be approaching rib number 5 because that is underneath her bordering hand, which is okay. So again, ribs 3, 4, and 5, not on the costal cartilage themselves, but the actual ribs. So I'm a little bit more lateral than the costal cartilage. I am doing a bit of a cross fiber strum of this muscle at the moment, but I am going to fire it off. So for me to activate this muscle, it does protraction, lifting that scapula forward, but because it's going from the ribs to the coracoid process, I'm actually going to ask her to try to depress her shoulder down a little bit. So not a pure forward motion, that's more of a serratus anterior, but a forward and down motion for that pectoralis minor. So I definitely easily can feel this muscle. I'm strumming it right now, and I'm going to follow it back up towards that coracoid, just underneath pec this time. So again, once you're on the belly, it should be fairly easy to navigate, working your way up. I'm now touching the inferior aspect of the coracoid process. And one more time, if you would just start to push your shoulder, good, right there, and that's good enough for us. So again, back to the insertion. It's preferred that you treat pectoralis minor directly, but it can be worked on through pectoralis major. I just prefer to get underneath pec major for that palpation. That's going to conclude our palpation of pectoralis minor. All right, in this video, we're going to be palpating the muscle known as Serratus Anterior. For the start of this, I'm actually going to bring my partner's arm up and across his body and just out of the way, as I'm going to be palpating a large number of ribs on the lateral aspect here. Serratus Anterior originates on ribs 1 through 9, but I often like to say it originates from ribs 9 to 1. The reason being, it's going to be easier to palpate ribs 9 than it is to try and find 1. So as we're going from the origin, I'm actually going to start in more of the inferior fibers and work my way up to try and get towards the superior fibers. The first thing that we're going to be doing is looking for the 10th rib. This is easier done because the 10th rib is the last rib that has a costal cartilage attachment towards the sternum. So the 11th rib is actually known as a floating rib. So I've actually identified his 11th rib here and felt the tip. So I know that this one's not connected to the costal cartilage. So that makes this rib in between my two fingers rib number 10. Just above that would be rib number 9, and this is our first muscular attachment for Serratus Anterior. It is not attaching to the costal cartilage, it's more attaching to the actual rib area. So I'm going to stay very lateral, and you almost want to think about being lateral to Pectoralis major, but anterior to your Latissimus Dorsi. So here's rib number 9, 8, 7, 6, 5, 4. I'm going to pause here again, making sure that you're lateral to that Pectoralis major and anterior to that Latissimus Dorsi. So there is a little bit of a window in here. So again, on rib number 4, I'm going to switch my hand, take my time sinking in a little bit. Rib number 3, I'm going to go up into his axilla and sink down towards rib number 2, and we're not going to be able to palpate rib number 1. So we're going to basically be able to count on the majority of people from 9 to 2. Now I haven't activated this muscle, so I want to show everybody from this camera view what it's going to look like. So I have his arm strategically like this as he's going to try to push his elbow up towards my hand. A common error is that people will have the full arm extended, but they leave it kind of bent. So it ends up being more elbow extension than it actually is the full scapulothoracic protraction. So I prefer to use a bent elbow and ask them just to push their elbow up towards your hand. So while I'm palpating the outer edge of that rib, I'm going to push down on that, and you'll start to feel some muscular belly sticking up on the ribs. So right in here, I'm able to feel that muscle belly quite easily, and I'm going to follow that up back towards that axilla. Another thing that you can do is by finding the edge of lats, you're going to try to push down lats, putting the flat part of your palm and fingers up against the ribs, and then as they lift up, you will feel this muscle belly lift up inside your hands. Take caution not to scrub really hard over top of the person's ribs, because most people will not enjoy that at all. So you can feel the majority of the origins and a portion of the muscle belly, but you will not be able to feel the insertion from this position. So I'm actually going to ask him to turn onto his side facing away from me. The serratus anterior fibers are running from anterior towards the scapula. Again, from anterior towards the scapula, and they go deep to the scapula. So the actual insertion point is on the anterior medial border of the scapula. So for that, I'm going to try and retract the scapula to soften up for me to get my fingers underneath. So one way for me to do that is, again, to position his arm and try to pull that scapula and humerus towards me. But again, if they're having difficulty letting go, we might change our hand position a little bit. I'm actually going to move around the camera person here in a little bit. So I'm going to take the weight of his humerus and his scapula. And I'm going to pull it back towards me as long as they're able to completely let go. And if not, we might change the arm position here a little bit, like so. And I'm going to reach my fingertips underneath in here and almost hook them. So I'll sit back down again so you can see this a little easier. So I'm pulling the scapula into retraction and actually feeling the anterior surface of that scapula along that medial border. There's a very close connection between serratus anterior and rhomboids. So if they have extremely tight rhomboids, it's going to be tricky for us to palpate serratus anterior's insertion. So that's going to conclude our palpation of the origin to insertion of serratus anterior. We're going to be palpating the muscle iliocostalis. We're going to be breaking it into 3 parts. So we're going to be starting in the lower section here with Iliocostalis Lumborum, and then we're going to go through Iliocostalis Thoracis, and finally Cervicis. So we're going to start with this erector down in the lower aspect towards its origin, which we're going to be palpating along the posterior iliac crest here, and then transitioning onto the sacrum. So this is going to be the origin of Iliocostalis Lumborum. It's the widest of the 3 erector muscles. So I'm actually going to ask my partner here just to lift up his back a little bit. Perfect. So as we are kind of seeing his SPs in this area, all of this muscle tissue through here, some of it's going to be some deeper paraspinals, but I am going to be palpating the outer or most lateral muscle tissue that's sticking up, which is this iliocostalis. You can relax back down. It starts to insert on the ribs in its name, costal, meaning rib. So we're going to be attaching to rib number 12, 11, 10, 9, 8, and 7. And 7 is going to be really, really close to the inferior angle of the scapula, just in case you're using that as a visual cue. So the rib angle is really this most posterior aspect of the rib, and that is where this muscle is going to be attaching. So I'm finding the rib angle, and then I'm pushing my fingertips in and just strumming the muscle tissue that is attaching in this area that's running in the superior inferior fiber direction. So again, I'm going to ask him just to lift his head and upper back out of the table here, and you can easily strum this iliocostalis. It is going to blend with longissimus, so you don't have to be kind of perfect with the activation, but just sticking to the most lateral of that erector tissue. And you go ahead and relax. So all of the erectors here are extenders, which is obviously in their name. However, secondarily, if you're talking on a unilateral side, they are going to be lateral flexors, so it would bring the spine this way, as well as they are ipsilateral rotators. So I could ask him to lift his shoulders up, a slight bend towards me on this side, and a little bit of a rotation towards me. So that would be extension, lateral flexion, and ipsilateral rotation of the trunk at these spinal joints. You can go ahead and back and relax. So that is going to be the same for all 3 sections, just depending on what part we're talking about. So this lumborum is really acting on the lumbar spine and the lower T-spine, and we will return for the next section. All right, we're continuing with iliocostalis, and the next section is going to be thoracis. So in its name, it's going to be the thoracic spine, and iliocostal, costal meaning in the ribs. So this muscle is more starting on the medial aspect and heading lateral. So keeping that in mind, it is attaching to the same ribs that the lumborum attached to, but the insertion for lumborum is more lateral than the origin of thoracis. So you're still going to find those same ribs. So I'm going to find rib number 12, 11, 10, 9, 8, and 7. And again, near that rib angle, but instead of saying a little bit more lateral, I want to be palpating just slightly more medial, where the origins of iliocostalis thoracis are. So the origin on those ribs, again near the angles from the lower half of your ribs, 7 towards 12, and then they start inserting, the lower fibers starting to insert onto the next rib, and they start jumping up, jumping up, jumping up. So our insertions are going to be starting right after the last origin. So this was 7, so we're going to start inserting on 6, 5, 4, 3, And then again up in towards rib 2 and rib 1 is going to get very, very tricky. You can't easily feel rib 1 from the section because it really is just curving to anterior. So in and around rib 2 is probably going to be one of the last ribs that you can feel. So again, I'm just continuing my cross fiber strumming near those rib angles to try and feel some of those fibers. And again, I'm going to ask my partner just to lift his upper torso up again. But as you get into the interscapular area, you're going to be going through multiple layers. So you have trapezius and rhomboids and serratus over top of it. So this is going to get a much harder palpation, and this muscle iliocostalis is really thinning out in this section. So don't expect to feel just perfect fibers. You can go ahead and relax. So you're going to sink down through multiple layers and then do a medial lateral cross fiber strum to try to access the erectors, which are running again superior inferior. So that's going to finish up this iliocostalis thoracis palpation. Again, as just a reminder, all of iliocostalis is doing extension, lateral flexion, and ipsilateral rotation like we did in the previous part of this muscle. And we're going to return for the cervicis part. And we are continuing with iliocostalis, and we're going to finish with the cervicis section. So we just finished palpating thoracis, and now we're getting into the more superior of the three sections. So this is continuing with its trend attaching to ribs, and it's named costal. So this origin, I'm going to be landmarking, looking for his cervical 7, which is also called the prominence. I am going to be utilizing his head to rotate to help me identify that I am on a cervical versus a thoracic vertebrae, this being T1, 2, 3. I'm going to move lateral until we find our first rib. So this will be rib number 3, and then I'm going to go count down from there. Rib number 4, rib number 5, and rib number 6. So ribs 3, 4, 5, and 6 near those angles is going to be our origin. And now, because we don't have any more ribs in the cervical spine, it is going to the more lateral landmark of the cervical spine, which is our transverse processes. So what I'm going to do from the back of his head is follow behind his ear until I find this mastoid process, which is right here. And then I'm going to drop just anterior and inferior to that. And this location is the TVP of cervical 1. I'm going to drop in behind his SCM, push it out of the way for number 2, number 3, and now our insertion for this muscle starts on number 4, number 5, and number 6. So 4 to 6 on the transverse process of the cervical vertebrae in here. So we have our origin, and then our insertion is going to be kind of creating this slight rotational, and then into the TVPs, more towards the posterior aspect of them. So instead of moving the torso, cervicis is going to act on the neck. So I'm going to ask my body to do is slightly lift his head up out of the cradle and slightly rotate towards us on the side and hold just like that. So this muscle is running from these uppermost ribs and going into the transverse process of the cervical spine. There's quite a bit of other muscle tissue that is covering over top of this iliocostalis, but again, you're just showing fiber direction and running your fingers along as best you can. And you can go ahead and relax your head in the cradle. So again, for this, just as a quick reminder, this is going to be acting on the neck primarily. So it is going to do extension. So if he lifts his neck straight up out of the cradle, it's going to do some slight lateral flexion towards the same side and some ipsilateral rotation, like so. And then you can bring his head back inside. And that's going to conclude all 3 sections of palpation for iliocostalis. All right, in this video, we're going to be palpating longissimus. Longissimus is one of the 3 erectors. It is, in its name, long. And it's going to be covering the large percentage of the back as a whole, going all the way from sacrum and pelvis all the way up to the head in the mastoid process. We are going to section this off into 3, and we're going to start off with the largest of the 3 sections called Longissimus Thoracis. Now, unfortunately, there's multiple different sources that have different opinions on all of the attachments. So I'm going to mention a couple here, but depending on your source, you might need to add or change a couple things. So I am going to be starting with our palpation of longissimus on the posterior aspect of the iliac crest. And I'm going to round the corner and go down onto the sacral crests, including the median sacral crest. And some will also talk a little bit more about the lateral aspect as well. So this is a kind of thoracolumbar-esque attachment. So you might have that written down or some connective tissue in through the lower back. And then again, depending on your source, some will reference that attaches to all 5 lumbar spinous processes as well as the TVPs. So to find a transverse process in the lumbar spine, I'm going to first identify the easiest of them to get to, which is going to be off of lumbar 3. So I found the SP of lumbar 3. I'm moving lateral, so ultimately I'm going past the erectors, and then I'm going to take some time and sink down with a decent amount of depth in here. You might not be able to get all the way to the depth of the TVP, which is fine, but you are just indicating that it attaches to the transverse processes. So this would be number 3. I would turn and angle my hand down towards 4. I will not be able to make contact with 5. I'm going to go back up towards 3. I'm going to change my direction towards number 2. And there's again a really good chance you will not be able to find number 1. So a majority of this right in this area is considered the origin of longissimus. And then it's going to start to insert on both the ribs and the transverse process of the thoracic spine. So again, depending on your source, I'm going to be going and just giving you my attachments that I usually follow, but again, you might have a slightly different one. I'm going to be finding the lowest rib, rib number 12, and following that as close as I can towards the transverse process. And then deep to my thumb here is going to be approximately the transverse process for thoracic 12. And then I'm going to count up together. So rib number 11 and T11, rib number 10 with T10, 9, 8, 7. Some sources will stop your rib counting in this area, but I am going to continue with my ribs. 6, 5, 4, and 3. So other sources will stop longissimus's insertion at rib number 3, but they will continue with your transverse process for number 2, as well as the TVP of thoracic 1. So that is every single transverse process of the thoracic spine, plus either a lower half of your ribs or possibly all the way up to rib number 3. So right as the rib starts to meet the spine and that transverse costal facet, that is where this longissimus muscle is going to be attaching. So as you are palpating in the erector group, oftentimes if you strum a larger muscle belly in comparison to some of the other ones, we usually attribute that to being longissimus fibers, especially in the upper lumbar spine and thoracic segment. It is a little bit more flatter and again more of a connective tissue attachment in the lower part where you might have more depth from a paraspinal. However, longissimus's bulk really is through this mid part of the back. And then as we get up towards the top and the attachment starts to get smaller and smaller, it is going to thin out as it turns into other muscle tissue. So that's going to be our palpation. Now again, just to fire it off to make sure we're in the right area, because I haven't done that yet. As of all of the other erectors, what I'm going to have him do is extend himself up a little bit. So not grasping the whole width here, but more focusing kind of on this center. You have spinalis, you have longissimus, and you have iliocostalis. You can relax back down. And again, just start to lift your head up again. Right in there, that's a really good activation of it. So you can follow all the way up to our highest attachment. So again, the erectors, lateral flexion, as well as ipsilateral rotation with that extension of the trunk. That's going to conclude our palpation of this part. However, we will return for the other two components. Continuing on with our palpation of longissimus, we're now going to be looking at longissimus cervicis, which is a much smaller section than the previous thoracis. I'm going to be starting at its origin, so we're going to be identifying where the cervical 7 and thoracic 1 spinous process are. So I'm just rotating his head, and the cervical spinous process should be moving, which is right here. So that helps me to know that this is thoracic 1. I'm going to palpate a little bit lateral to identify approximately where the transverse process, so TVP of thoracic 1, number 2, number 3, 4, and 5. So the origin of longissimus cervicis is the transverse process of thoracic 1 to 5, and then it's going to be also making its way up into the transverse processes, similar to a previous muscle in Iliocostalis. So I'm going to be identifying where his mastoid process is. I'm going to drop off anterior and inferior to find the TVP of C1. I'm going to go a little bit below that, push his SCM out of the way. So here is number 2, and this is the beginning of our insertion. So TVP of 2, number 3, 4, 5, and 6. So along this section of his spine, and again towards the posterior aspect of those transverse processes. I'm going to get him to do a gentle activation, so he's going to slightly lift his head up out of the cradle and look towards me just a little bit. Good. And go back down again. And right in there, I'm starting to feel a little bit of a ropey band. Again, whether this is exactly longissimus or not, that's hard to say, but you're just going through kind of the motions of palpating from the transverse process of the upper thoracic spine into the transverse process of basically almost every cervical vertebrae, 2 to 6 in there. Again, just like the other erectors, we have extension, lateral flexion, and ipsilateral rotation. So our fiber direction is running up and into the side of the neck like so. So that's going to conclude our palpation of cervicis, and we will return for capitis. We're going to be finishing off longissimus by palpating longissimus capitis. Longissimus capitis and cervicis have some overlapping origins, but capitis is actually slightly bigger in its attachments. Again, I'm going to landmark and try to find our cervical versus thoracic spinous process. So I've identified thoracic 1. I'm going to move over, and I'm going to repalpate the same transverse processes of the thoracic spine, whether it's the upper 4 or upper 5, again depending on which source you're using. However, for capitis, it actually goes higher, and it goes onto the articular processes of the lower cervical. So again, if I'm finding cervical 7, we have the SP, the lamina, and then kind of sinking into the side to find articular processes. So there's number 6, number 5, and number 4. So the lower articular processes as well as the upper thoracic spine TVP. So this is going to be our origin in this pathway along here. And capitis, capitis meaning head. So instead of the neck where cervix is attached, it is actually, we're going to continue on with our palpation of longissimus capitis. So we've already gone through cervicis and thoracis, and now we're just going to be finishing off with capitis. First thing I'm going to be doing is trying to identify his cervical 7. So I'm taking his head and again gently rotating it, feeling for the moving spinous process, which I've identified as this one, and the thoracic 1 does not move as much. So I've identified T1. I'm going to move lateral, and I'm going to find the transverse process. So cervicis and capitis have some overlapping origins on these upper transverse processes of the thoracic spine. So again, I have 1, 2, 3, 4, and depending on your source, 5. But other than cervicis, it actually has some attachments onto the lower C-spine. So after you found the TVP of C7 and T1, you're going to sink into the articular process of the lower cervical. So this being C7, going a little bit higher, And now I'm into the articular process of 6, 5, and 4. So these are our origins all along here for Capitis. And then Capitis meaning head, so our insertion is actually on the mastoid process of the temporal bone. So in behind the ear, dropping down, you'll be able to easily find the mastoid process. However, this is the third layer in. So you have Sternocleidomastoid, as well as slightly underneath that from this direction is Splenius Capitis, and then underneath that is going to be Longissimus Capitis. So there's a really good chance you are not being able to find its fibers specifically. That being said though, I'm still going to ask him to gently lift his head up out of the cradle and turn towards me just a little bit. Good. And we are going to strum some fibers back down towards those articular processes and TVPs. There's a really good chance you are feeling Splenius Capitis instead of Longissimus Capitis, but that's okay. They are working together as synergists to do that extension and ipsilateral rotation of the head and neck. All right, and you can bring your head back down. So that is going to conclude all 3 sections of Longissimus. All right, we are going to be palpating the muscle called Spinalis Thoracis. Spinalis Thoracis is the most medial of the 3 erectors. You have Iliocostalis, Longissimus, and then Spinalis. And the biggest section of it, and really the only palpable section of it, is in the thoracic region. So we're going to first be starting the origins. Since this muscle is the most medial of the 3, it's originating actually on the sides or the lateral side of the spinous processes. So I'm going to start by finding the iliac crest here, following it over towards the posterior superior iliac spine, heading medial until I find our lowest spinous process for number 5. And I'm going to count up 4, 3, 2, and 1. So the lumbar spinous process number 2, as well as number 1, and then above that on thoracic 12 and thoracic 11. So these are the 4 origins on the lateral side of these 4 spinous processes. These are our O's, and then the muscle is going to start attaching at spinous process above that. So once again, that was lumbar 2, lumbar 1, thoracic 12, thoracic 11. It's going to skip number 10, it's going to skip number 9, and then it starts attaching at 8, 7, 6, 5, 4 in this area here. So you have 4 origins and 5 insertions, and the muscle is going to be getting kind of this like rainbow effect where the lowest attachment actually goes to the highest attachment. So the lowest origin around L2 is going the highest in the T-spine. And then you have the shortest segments right in the middle between T11 and 9. So the best way to palpate this muscle is to first find the SPs, roll slightly off to the side, and then this is going to be doing extension primarily, again with all the other erectors. That's going to be its main function. So we're going to ask him to extend his trunk up. And if I take my hands away for a second, you'll actually see a little bit of an indentation in the center of his erectors. Ignore a little bit of his trapezius in this area. He's going to relax back down again, and we'll get that to fire again. So watch very carefully right in this area. He's going to slowly so right in this area, right in here, right up against the SPs, this is Spinalis Thoracis, and the best location for you to be able to strum it. And again, you can relax back down. So the person has quite a tight back muscle tissue. If you go right up against the SPs, and you strum in a medial lateral fiber direction, you might come across some taut bands that are quite stringy as you go all the way up along the side of the S-piece in that section right there. Because it attaches from spinous process to spinous processes, this muscle really does not do any sort of rotation. So acting bilaterally, it is going to be an extender of the spine. But if you were acting unilaterally, it would also work with some lateral flexion. So again, extension and lateral flexion of the spine is going to be the actions. And that's going to conclude our palpation of Spinalis Thoracis. We're going to be palpating the muscle Splenius Capitis. Splenius Capitis is one of the muscles that works in conjunction with your erectors. It is an ipsilateral rotator, and capitis meaning head. So this muscle is going to be attaching from spinous processes in towards the mastoid process. Depending on your reference, it's going to be starting at either cervical 3 or cervical 4. So I'm going to be starting on his external occipital protuberance of the occipital bone. I'm going to run down till I drop off. This should be approximately where C1 is. The first large spinous process I can feel is cervical 2. And then just after that into the dip is going to be the beginning of C3. So 3 or 4, 5, 6, and 7. So this is all by way of the ligamentum nuchae. And then after 7, it's going to be thoracic 1, 2, 3, and 4. So you have C4 to T4 on the spinous process on the lateral aspect. So this is our origin, and then it's going to be traveling superior and lateral on an oblique heading in towards the mastoid process. So following just behind the ear, you can drop into the mastoid process. Sternocleidomastoid is the first kind of more superficial muscle, but I'm actually going to go in behind it, kind of push SCM out of the way, and then I'm starting to be able to strum a belly that's kind of following this fiber direction. This sternocleidomastoid is actually going to be a contralateral rotator. So if I ask him to look towards this side, it actually slackens off and lengthens his SCM, but it shortens and tightens up his Splenius Capitis here on the right-hand side. So I can get a really nice grip on Splenius Capitis, and I'm going to follow it down until it starts to go underneath his trapezius here and underneath near semispinalis. So it's actually superficial to semispinalis, but you will lose it as you go underneath upper traps. So continuing with your palp, you're then just going to start pushing through trapezius and then into rhomboids to get down towards that thoracic 4 attachment. Go ahead and relax your head in the cradle. So again, quite a long origin, and then it starts to really thicken up as it attaches to the mastoid process of the temporal bone. Again, last, just repeating myself, this is an extender. It laterally flexes and ipsilateral rotates the head and the neck at the spinal joints. So as if you're really trying to look over your shoulder on that side. Again, if you want to lift your head up and look towards that side, great. That's going to be its main function. It really is a big rotator of the neck and head. And you can bring your head back inside the cradle. So that's going to conclude our palpation of Capitis, but we will return for some palpation of Cervicis. So we're continuing with our Splenius palpation. We've already palpated Splenius Capitis, and now we're going to continue on with Cervicis. Cervicis is a little bit lower in its origin, and it's also inserting into the neck instead of the head. So the first thing I'm going to be doing is, again, just doing a gentle rotation of his head in the cradle here. I've found cervical 7, so I'm going to count down 1, 2, 3. So it's starting to originate on the spinous process of thoracic 3, 4, 5, and 6. So our origin is here, spinous process thoracic 3 to 6, and then it's going to be traveling up and lateral in the direction of the transverse processes. I'm going to use the mastoid process. I'm going to follow it down, drop off inferior and slightly anterior. This is going to be the TVP of C1, and then I'm going to go behind that for 2, 3, and 4. So in this area here on the upper transverse processes, either 1 to 3 or 1 to 4, again, depending on your source, this is going to be our insertion of Splenius cervicis. So along with Capitis, this is a major rotator. So he's going to lift his head up out of the cradle and look towards that same side. Good, and that's bringing the neck closer towards these spinous process origins. And you can, again, bring your head back. So it is deeper than Splenius capitis. So you're going to have a little bit of a challenge trying to follow this. I'm sinking through trapezius, rhomboids, and serratus posterior as I'm working my way from SPs towards the transverse processes in the cervical spine. So again, if you're doing kind of techniques that go up and heading from spine towards neck, there's going to be multiple muscles, whether it's the splenius muscles or the erectors, that are all helping with that ipsilateral rotation. So again, anything's really going to be helpful if you're trying to treat in that fiber direction. That's going to conclude our palpation of the 2 splenius muscles. We're going to be doing a video here for Semispinalis capitis. There's going to be 3 sections of it, but we're going to be starting off with Capitis. So Semispinalis capitis is a very large muscle in the posterior aspect of your neck that extends down into your upper back. And I'm actually going to be starting at the insertion and working my way back towards the origin. It's very easy to find this muscle if you're starting on the spinous process in the back of the neck and you ask your person to just lift their head up slightly out of the cradle. If you moved lateral over top of the lamina, this big portion of muscle that's sticking up right here is semispinalis capitis. So I'm actually grabbing it on either side and I'm going to follow it right up into the back of his occiput. Now he's going to relax for me, put his head in the cradle. So I've identified the external occipital protuberance here. And if I go off lateral to that, this is the superior nuchal line. And then I'm going to drop deeper or towards the neck. So this insertion is between the superior and inferior nuchal line of the occipital bone. So again, if you were to sink in and they lift their head up slightly, it'll easily be pushed off and then relax. Or I could grab the muscle belly and follow it right up into the base of the occiput here in between those two. So this is our insertion. It's quite a thick muscle. We use it quite a bit to extend the neck and the head. Now for palpating the origins, it has quite a bit of origins that run down along the lateral vertebrae. So I'm going to be starting by finding his thoracic 1 and cervical 7. So I've identified C7 and T1. I'm going to move over and I'm going to palpate my way down along the transverse process of thoracic 1 to 6. Okay, good. So again, finding T1 and counting your way down, and I'm just using my spinous process palp as an aid to make sure I'm in the right space. So all along here over top of the transverse processes of the thoracic spine. And then again, back at C7, it is the transverse process of cervical 7 plus the articular processes of 6, 5, and 4. So you have your SPs, you have your lamina, and then you have your articular processes of those inferior cervical vertebrae. So those are the origins from cervical 4 all the way down to thoracic 6. Lateral. So that makes this fiber direction go pretty close to straight up and down, which is why it really is a good extender of the head and the neck. So again, he's going to lift his head and his neck and look forward just a little bit. Great. So that is the main function of this muscle, especially acting bilaterally. If you are acting unilaterally, it can do a little bit of a lateral flexion. So again, he's going to lift his head up. It slightly tilts towards the side. But there really isn't going to be a lot of rotation. Again, depending on your source, it might discuss a little bit of a contralateral rotation, just bringing that slightly closer towards those TVPs, but other sources really only list this as 2 extension and lateral flexion of the head and neck at the spinal joints. That's going to conclude Capitis, and we will return for the other segments. All right, continuing on with our palpation of semispinalis, we're now going to look at cervicis. So what you're going to do is palpate down and try to find the cervical 7 and thoracic 1. You've seen me do this before, but I am going to be using the neck to create rotation of that 7th cervical. Once I've identified thoracic 1, I'm going to move lateral towards its transverse process. Again, depending on your source, you might have some textbooks talking about a little bit of C7, others will start at thoracic 1, and it's going to go down 3, 4, and 5. So it is the transverse process of the upper thoracic vertebrae in here. And with all of the paraspinal muscles, including semispinalis, they originate lateral and insert more medial. So you have the upper T-spine inserting into the upper C-spine. So I'm going to palpate from his external occipital protuberance of the occipital bone, go down, drop off towards C1, and its first insertion is going to be on the spinous process of 2, 3, 4, and 5, and possibly 6, again depending on your source. So the upper spinous process of the cervical vertebrae from the upper transverse process of the thoracic vertebrae. With this fiber direction, these muscles are going to extend and do a slight bit of contralateral rotation as well as a slight bit of lateral flexion. So he's going to lift his head up, there's the extension, and he's going to look towards me, which is away from the side the muscle's on, and now they're lining themselves up. So that is the contralateral rotation. And again, if you laterally flexed a little bit, you might be able to. If not, don't worry about it. Good, so let's go back down towards the cradle. So that's going to be extension, lateral flexion, and contralateral rotation of the neck as its primary action. And this muscle tissue is not on the surface right away, so you have to palpate through other layers, and it is going to blend a little bit with semispinalis capitis since that one is more superficial. So again, you have origins and insertions. That's going to conclude our palpation of cervicis, and we will return for thoracis. All right, the last section that we're going to be palpating of semispinalis is the thoracis segment. So you can either start from the bottom or the top. Our attachments are going to be the TVPs in and around thoracic 6 towards 10. So again, you can either start by trying to identify where 10 is, or you can count down towards where 6 is. I'm just going to do a quick count down. Thoracic 1, 2, 4, 5, and 6. So I'm going to palpate lateral towards the TVP, and then I'm going to work my way down 7, 8, 9, and 10. So these are the transverse process of thoracic 6 to 10 in this area here. Again, I am pushing through some erectors. I'm not getting a really good palp of those TVPs. I'm just more in the general area. So we have our origin in this space here, and then we're going to go back up towards the top, again identifying where cervical 7 is in this area. So attaching to the spinous process of 6 or 7, again depending on your source, T1, 2, 3, and 4. So from this mid to lower thoracic spine to the upper thoracic spine. So again, same as the other sections of this muscle, it is a main extender. However, its fiber direction along with cervicis turns into a contralateral rotator. So if he was to extend and lift his head up out of the cradle and then start to rotate away from the side the muscle is on, so towards me, great. So past the neck, once he starts moving that T-spine a little bit, he is going to be creating that contralateral rotation. So again, you can go back down to the cradle. So along with rotatories and multifidi, semispinalis is the contralateral rotator of the spine. And semispinalis is really only in the upper part of the body where you'll see more multifidus in the lower portion of the body. So you have a greater concentration of multifidus here, but you will see more from semispinalis up in here. So again, transverse processes 6 to 10, inserting towards spinous process of cervical 6 or 7 down towards thoracic 4 on those SPs. Extension, lateral flexion, and contralateral rotation. And that's going to conclude our palpation of all 3 segments of semispinalis. All right, we're going to be palpating 2 muscles in this video. We have a superior and an inferior, and we're talking about serratus. So you have a serratus anterior, but maybe a little less known muscle that we have in the back are the serratus posterior, and there is a superior and a serratus posterior inferior. And both of these muscles are going to be originating on their respective spinous processes, and both of these muscles are attaching to ribs near around their rib angles. So for the purposes, I'm going to start on the lower one, and I'm going to count myself up towards the spinous process of lumbar vertebrae number 2. So we're going to head central here. So we have 5, 4, 3, and number 2. So this is going to be our lowest origin. I'm going to count up 4 segments. So lumbar 1, thoracic 12, and thoracic 11. So the spinous processes of lumbar 2 through thoracic 11 is our origin. This muscle is going on an oblique angle, heading superior and lateral, and it's actually more superficial than your erectors, which means it goes over top of that group of erectors in the Iliocostalis and Longissimus, and it's attaching to the ribs. So we know that Iliocostalis, in this case lumborum, is attaching near the rib angles, and this muscle, serratus posterior inferior, actually goes past that to a similar ribs. So it attaches to the inferior 4 ribs. So we have rib number 12 right here, and rib number 11, number 10, and number 9. So we have our kind of like a little quadrant right here for serratus posterior inferior. Now, because this is attaching to the ribs from the spinous processes, it could, in theory, do a little bit of lateral flexion, but the main action this muscle is going to be focusing on is going to be pulling down or depressing some of these ribs. So as you inhale really, really deeply, you have a few different sections of ribs that are doing different actions. So as you take a deep, deep, deep breath in for us, these lower ribs are getting pulled down just a little bit, and you can exhale. And our middle ribs are kind of almost expanding out a little bit, and the upper ribs are going to elevate. So again, depending on which text reference you're going with, there is some controversy on its actions and when exactly each one of these is firing. But we're going to be sticking as a simple one, as when you're taking a deep, deep breath in, some of these inferior 4 ribs are going to be held down or move slightly inferior. So if you can, again, take a nice deep breath in for me and just kind of hold that. And I'm going to be cross-fibering in the fiber direction where the serratus posterior inferior sits. It is going to be trickier because it is sitting underneath the Latissimus Dorsi and some of that thoracolumbar fascia. So you might not feel it, and you can go ahead and let go of that breath. Thank you very much. But let's say your person is running, or they've been doing quite a bit of coughing, then they might end up with a little bit of a low back pain right in this area. So again, if they take a nice deep, deep breath in, and while you're pushing on it, that pain goes up, that could be something coming from serratus posterior instead of just a low back abdominal muscle. And you can relax. Good. So there is our serratus posterior inferior. And I'm just going to continue on, jump up towards the superior. So the first thing I'm going to be doing is finding the spinous process of cervical 7, which is also known as the prominence, and then thoracic 1. If you've seen previous videos in this area, what I typically like to do is place one finger pad on what I believe is cervical 7 and one on thoracic 1, and then I'm going to passively move the neck in the cradle and feel for which one of those spinous processes is moving. So I've identified this one as the cervical 7, therefore this is thoracic 1. So this muscle has origins again on spinous processes, like its inferior partner, and it attaches to cervical 7, thoracic 1, thoracic 2, and thoracic 3. So in this section right here on the sides of those spinous processes, and then the muscle, just like the lower segment, runs inferior and lateral, covering over top of the erectors in this location and inserting into the rib, just kind of past that angle. Now this is going to be very tricky to feel because we're getting into the third layer here with both trapezius running in this direction over top of it, plus in the exact same direction we have our rhomboid muscles going through here. However, rhomboid was attaching more to the scapula, and this muscle is attaching again to those ribs. So what I'm going to do is try to find a segment where I might feel maybe a little bit of a top band. Again, I'm going to go back and forth in that section where we have serratus posterior superior, and then I'm going to ask for my partner to take another nice deep breath in, deep breath in, and see if I can feel some tightness going on there. And he's going to exhale. If you feel something tightening up a little bit, you can also ask them to engage their rhomboids by gently trying to squeeze their shoulder blades together. Good. And relax. So that should feel completely different from more trapezius and rhomboids, which are retracting the scapulas together, versus this muscle, which is going to be elevating the second through fifth rib during inhalation. Another method that you can sometimes get these ones to flare is by asking a person just to do a quick little cough. So again, let's try that one more time. Perfect. So you're engaging some respiratory muscles as they're pulling up on the ribs, trying to inhale or exhale forcefully. So again, from cervical 7 to thoracic 3 spinous process, and rib number 2, 3, 4, and 5 past the erectors near that rib angle. So this would be the segment section for serratus posterior superior. So that's going to conclude our palpation of the two serratus posterior muscles. All right, we're going to be palpating the Quadratus Lumborum muscle next. So I'm going to be just taking the person's arms, moving it out of the way. This gives me a little bit easier access to this area. So Quadratus Lumborum is the most posterior of your abdominal muscles, and it really is kind of deep within this low back. Again, there's going to be some controversy out there about how easily you can or cannot palpate it because it is very deep. It is through all the layers of your erectors, a little bit out to the side here, and then through all of the abdominals. But we're going to go through kind of the O's and I's and palpation of it generically, and then you guys can think about how well you're actually contacting or not. The pelvic attachment for this muscle is here along the posterior iliac crest. So I'm just sinking in along the top of his iliac crest, and it again is very deep, more on the anterior part of that iliac crest. And as it makes its way posterior towards the sacrum here, again, very, very deep in this location, not easily able to feel this, I'm more just over top of it. This is me cross-fibering what is known as the iliolumbar ligament. And this iliolumbar ligament is going from the iliac crest, heading towards the transverse process of the 4th and 5th lumbar vertebrae, which are going to be quite deep in this location. So, origin, iliac crest, and the iliolumbar ligament. The muscle then continues and starts attaching along all of the transverse processes, versus in other texts we'll talk about just 1 through 4, but because of that iliolumbar ligament, that's where it gets the 5th. So I'm along this 3rd one here, going a little bit higher into number 2, and again, that transverse process of lumbar 1 is going to be underneath rib 12 and very tricky to feel, so it really depends on the person and if you're able to actually feel that. Another method to try and get in the approximate area is to use a spinous process. So I'm going to walk myself central. Here is a spinous process of 5, 4, and 3. So once you've found the spinous process of lumbar 3, move lateral past the erector spinae group. If you wanted to prove that, you could ask them to gently just lift their head and neck up out of the cradle. There we go. There's the edge of his erectors here. So I'm going to sink in lateral to the Iliocostalis, and you can go back down. And then I'm going to sink in on an oblique angle, kind of almost like a 45-degree angle here, going deep and medial until I feel some bony resistance. So I'm getting a little bit of bony resistance, and I believe I have found the transverse process in the lumbar spine. If you need to, you can ask your person to take a couple nice, slow, deep breaths in, and then on your exhale, you kind of sink in and follow it. This will allow some of the muscle tissue to relax a little bit to make sure you've really sunk into this kind of quadrant at the back. Finally, we're going to ask our person to do what is known as a hip hike. So basically what he's going to try to do is bring this whole leg up, good, just like that, towards his shoulder. You might have to teach your person this a couple times, and you can relax for me, but basically they're trying to slide their leg up, not flex their hip. So if you watch really carefully right over top of my fingertips, when I'm over top of the Quadratus Lumborum and he goes through that action, I'm going to get pushed up. Yes, absolutely, there's going to be some abdominal muscles firing in this area, and you can relax. But deep to that, Quadratus Lumborum, one of its actions is to elevate the ilium, or a layman's version of that would be a hip hike. So let's do that one more time. Just a nice little good, perfect, that's enough for us, and you can relax. So there's quite a bit of function of the Quadratus Lumborum here. I'll just finish off by contacting the last attachment as we discuss the actions just after that. So we've had iliac crest, iliolumbar ligament, the transverse processes of lumbar 4, 3, 2, 1, and lastly the inferior surface of rib number 12 here. So again, I'm just going to sink in and try to hook my fingers to the inferior part of that rib 12, and if you could just gently start to raise that hip, that's enough, perfect, and you can relax for us. So the actions, because again, we can move these ribs down or we can laterally flex. So we have an inferior movement of rib 12. We have lateral flexion of the trunk and spinal joints. If you activate both QL together, that would help extend the spine. On unilateral, it's going to start to elevate the ilium on one side, and as well as you can pull on this pelvis going into more of an anterior pelvic tilt at the lumbosacral joint. So we have quite a bit of action for a tiny muscle that, again, controversial on how much you're actually palpating it versus the other abdominal muscles. That's going to finish our palpation for the Quadratus Lumborum. All right, we're going to go through just a little extra video here on how to get into the Quadratus Lumborum from a sideline position. Oftentimes, you'll see QL listed on some cases, maybe inside of your exams, for something to do with something like scoliosis or even a pelvic lift. So we often would use a sideline position when treating scoliosis. So I'm going to show you an alternative method to kind of get in that Quadratus Lumborum. So here is our spinous processes in the lumbar spine. Again, moving lateral past a lot of these erectors. You can already kind of see a little bit of the hyperemia from where I went in from the prone position here. Here is the bottom of the rib 12, and there is that iliac crest through there. So basically what I'm going to do is I'm going to go directly above this, where I'm still lateral to those erectors. He's going to take a nice, slow, deep breath in for me, and on that exhale, I'm sinking in until I get a nice bony resistance right across the transverse process of the lumbar spine in here. So again, a couple different ways to kind of access that. Once I've landmarked it, I might reinforce my fingers gently. Another nice deep breath in for us. Beautiful. And relax. And ever so gently, if you can start to do that hip hiking, bring that ilium, perfect. And as soon as he does that, my fingers are getting pushed out and he's going to relax and we can go back in. So sometimes that good old trigger point location, you might just be kind of pushing in here, whether you're releasing it, something like that or not, or just some digital pressure into the lateral abdominals where the QL would be, will be helpful to try and loosen up this quadrant of the lower back. All right, in this video, we're going to be going through the palpation of the external abdominal oblique. So as you can see, we have our person in the supine position. And for this, I'm going to be actually palpating a crossbody, making it a little bit easier for the camera to see. But also, when I'm palpating ribs, I really like to have my hand as flat as possible over top of these ribs. Just as a kind of a poor example, I don't want to do this to them too much. But if I'm often standing on the same side, I end up going in with more fingertips. And if your client is ticklish, they're really not going to like you having kind of jabbing fingers into ribs. or if you're palpating more across body over top of ribs, you can actually stick your fingers more in intercostal spaces. You're having a broader pressure, it often overrides a tickle sensation and makes it a little bit easier for you to count and for them to tolerate what you're about to do. Okay, so we're going to be going through the origin and the insertion, obviously. In the Rectus Abdominis video, if you've already watched that, we've discussed that the pelvis is more stable, so a lot of textbooks often consider this one the typical origin, and then our ribs being more of the insertion. So depending on which reference text you're using, you may see one or the other. So we're going to start with the pelvis today. So I'm going to get my person to start by taking this part of their hand, known as the ulnar border part of their hand, and kind of walking down the pelvis until they feel a bony object. Do I have permission to palpate everything above your hand?
Yes.
Okay. So what I'm going to be doing is starting at in around the umbilicus, and I'm going to be walking down until I feel the pubic bone. In the center here is the pubic symphysis. Just lateral to that is known as the pubic crest, and finally a little bit further than that is known as the pubic tubercle. So the external abdominal oblique is attaching to this pubic tubercle as well as the pubic crest. So that's two of its origins. Another one of its origins is down the center seam here, known as the linea alba. But again, depending on your reference, they also might talk about this abdominal aponeurosis. So this abdominal aponeurosis is a sheath that's covering over top of rectus abdominis. So some texts will say that the obliques end here, and this is again more of a connective tissue, versus some are saying that connective tissue from oblique goes all the way to center. So you might read either one of those. So that's the third origin. If you're able to move your hand away now just for a second, I'm going to go and palpate right to here, otherwise known as the anterior superior iliac spine. And then this muscle also attaches here along this anterior iliac crest. So you have the anterior iliac crest, you have the pubic tubercle, pubic crest, and the linea alba as your origins. Now the muscle fiber direction of our external oblique actually comes down this direction. So for some people, again, thinking more the ribs or the upper attachment, and then these pelvis bones are more the insertion. So because of that, this muscle has a contralateral rotation action. So all of your abdominal muscles typically help flex the trunk at spinal joints. However, this contralateral rotation is going to be coming by pulling these ribs towards the opposite side. So what I'm asking my person to do right now basically is a contralateral rotation crunch, where he's trying to bring his elbow across the other side of the body, and you'll start to see some of those external oblique fibers sticking up. And you can come back down. Excellent. So the other attachment for external oblique is going to be the lower ribs. So depending on which reference, oftentimes it's ribs 5 through 12, or otherwise known as the lower 8. So I'm actually going to start by reaching all the way around and in behind, and the last rib of the rib cage, which is one of your floating ribs, is known as rib 12. So right in this area, and then just above that, we have rib number 11. The first one to connect into the costal cartilage will be number 10, 9, 8, 7, 6, and 5. And just as one of those notes, oftentimes rib number 5 is really, really close to the male areola. So that might be just a nice, easy reference point if you're working with the male. So the origins or insertions all along the ribs, not the costal cartilage, but the actual ribs themselves, which means they're more on that anterolateral surface of those ribs. So again, fibers running down towards the center here, and then down towards the pelvis down here. So one more time, I'm just going to ask him to do a little bit of that lateral rotation crunch. Good. So right along here is our muscle fibers, with a large concentration of that muscle being over top of these ribs in here. We're going to go through internal oblique in a different video, but what's interesting, I'll just point it out, is that the external fibers are running this way over top of the internal fibers, which are running this way. So you really want to focus on this muscle fiber direction running inferior and central. All right, that's going to conclude our palpation of external abdominal oblique. Alrighty, in this video, we're going to be palpating the internal abdominal oblique. So again, we have a person in the supine position. We're going to be palpating from pubic and pelvic area all along the this iliac crest, and then as well as some ribs. So as a continuing trend with a lot of these abdominal muscles, if you've been watching them, I usually keep the pelvis as the origin. So for this, the internal oblique has 3 attachments, but they actually extend quite a bit back. I'm actually going to ask you just to bring your arm up out of the shot here for a second. Excellent. So attaching all the way along this iliac crest, which goes all the way posterior and into what is known as the thoracolumbar fascia. So I'm actually going to reach all the way back into some of this connective tissue back in this area here. So this is a part of the origin, the entire iliac crest all along here. And then as it gets to the ASIS, it's going to then start working its way down along the inguinal ligament. So just for safety's reason, I'm going to ask you to use this hand and create a border. So he's sliding his hand down, kind of finding that bony area. And do I have permission to palpate above your hand?
Yeah.
Okay, so all along here is our inguinal ligament, and that connects down to our pubic tubercle. So inguinal ligament, iliac crest, and thoracolumbar fascia as that origin. Putting a lot of internal obliques muscle fibers in this lower quadrant in here, where in the previous video we talked about external oblique having a lot of fibers up in the rib area. So that is the origins, and you can move your hand away now. The insertion is going to be all the way up along the linea alba, or again, as we discussed before, so we'll reference it more over laterally on the abdominal aponeurosis here. So again, that internal oblique is going to have fibers running this way, and then it's going to insert to the lower 3 ribs. So I'm just going to be reaching my hand around towards the back, feeling for this most inferior rib, rib number 12. So that is right in this area here. Going a little bit higher, this is rib number 11, so 11 and 12 being our floating ribs, and then this lowest rib attaching to the costal cartilage here being number 10. So those are the insertions, as this muscle has fiber direction running more like this. So to fire off this muscle, I'm going to be palpating in this kind of lower quadrant, and I'm actually going to ask him to bring his left shoulder towards his right hip. So whenever you're ready to do that, excellent. So this is a ipsilateral rotation and flexion of the right internal abdominal oblique. And you can come back down. So this muscle is going to be responsible for ipsilateral rotation of the trunk, as well as flexion and lateral flexion of the trunk towards that side, as well as it's going to grab this pelvis and kind of lift it up and go into more of a posterior pelvic tilt. So those are going to be the actions. Again, just last one more, again, just to confirm that our muscle is definitely in between the iliac crest and the rib in this area, and it has our fiber direction running more like this. So that'll conclude our palpation for internal abdominal oblique. All right, we're going to be palpating the transverse abdominis. So I prefer to start off in a sideline position, since this muscle really is going as far back as the thoracolumbar fascia, and it's going to be attaching kind of up and down on iliac crest as well as ribs and making its way towards the linea alba. So I like to start off in a sideline position just so I can get a little bit better access to that low back area. So I'm going to start off by palpating his 12th rib right in this area here, and then kind of rounding the corner onto this thoracolumbar fascia in the low back, and then onto the iliac crest as I work my way anterior along the iliac crest, and then onto just the more lateral part of the inguinal ligament. Are you comfortable with me kind of working just past that? Okay. So I'm not going to go too far in this position. I will turn him into a supine position to kind of finish off that palpation, but there's a portion of it, and then I will round the other direction, counting up along kind of that lower costal cartilage and rib attachment as it goes from ribs 12, 11, 10, 9, 8, and 7, which means the xiphoid process, and it really is just along that inside edge of those ribs. So it doesn't go over top of the ribs, it stays right to kind of that internal almost aspect of it. So we have a broad origin here, and I'm going to ask my partner just to turn onto his back for me. So that muscle is coming from the posterior as it's working its way, and that's going to start to spread out as it goes along the iliac crest and the inguinal ligament and towards the pubic bone as well as towards the xiphoid. If you would be so kind as to reach across, you're going to create a border with your opposite hand, just turn across that pubic bone. Good. So I'm going to palpate down along the inguinal ligament and then get towards that linea alba. So this is its insertion all along that linea alba and that kind of rectal sheath all the way up to the xiphoid process where it has that costocartilage of rib 7. So you have a broad muscle in here that goes from posterior running forward into the center. So because its fiber direction is really transverse and both parts are equally grabbing, all it really does is pulls equally and then actually ends up compressing the abdominal contents flat. If you're able to remove your hand away for us, just so we can kind of see that. And the idea here is that you're going to try to take your umbilicus or your belly button and try to suck it and tighten up your core towards your spine. Excellent. Just like that. So what I'm going to do is get you to relax now. So to feel that, I'm going to go on both sides. You can do this unilaterally or both sides. You're going to kind of squeeze in between the iliac crest and the ribs, and then you're going to get them to do that action again. Pull their belly. Excellent. And what you'll feel is that muscle almost wants to flatten and pull out in this direction here. So he's going to relax. So oftentimes people believe this is one of the really, really important core muscles, and that's people have difficulties engaging it. So this is something you really want to test to see if your person is able to engage their transverse abdominis. And then you might have to teach them some exercises to engage it. We don't have a manual muscle test for this. And again, a length would be basically trying to pull the belly button away from the spine. So that's not really something that we go through. So it really is more about your palpation and are they able to engage? And then you might do other abdominal exercises, maybe something such as a plank, just to see how well they can engage this transverse abdominis. So let's get one more activation of this just to kind of see. So again, he's going to try to pull his belly button tight, tight, tight towards the spine. Good as that flattens out, and this part starts to get engaged along here as that belly button gets pulled towards the spine. And you can relax for us. Excellent. We're going to be palpating rectus abdominis in this video. So as you can see, obviously we have our person in a supine position, and we're going to be going through both palpation in and around the ribs, as well as down towards the pelvis and the pubic bone. So for the beginning of this, since it's kind of arguable on which one is more the origin versus the insertion, some textbooks will believe that more the stable pelvis is the origin, where others will go with more the ribs. And the reason for this is because the ribs could move closer towards the pelvis, or technically your pelvis could roll posteriorly up towards your ribs. Therefore, both of them have some connection. As a person's typically doing just a little bit of a crunch, you can go ahead and just do a quick sit-up, you have both the abdominals moving in both directions within this. And that is one of the reasons why, again, both origins can flip. So I'm going to be starting off with the pelvis. So I'm going to be asking my partner basically to take his part of his hand and kind of walk down the front of his abdomen until he feels a bony object in this area. And you're just going to lay your hand across that, and I allow to palpate above your hand today. Yeah. Okay. So typically this is creating a border, and we want them to use the opposite side hand versus the side that you're on, because then it gives you better access to kind of palpate in this area. So we have a border, we have permission. Now typically what I'm going to do is start just below umbilicus and walk down the center, which is known as the linea alba. And when I get towards the bottom, right in the center here where the two pubic bones meet, that is known as the pubic symphysis. So this pubic symphysis and just off to one side is known as the pubic crest. These two central origins for rectus abdominis here. So it's quite narrow towards the bottom in more of a bilateral palpation. It would look about this wide. Again, if you just slightly bring your head, and perfect, that's enough to activate the lower rectus abdominis attachment. You can relax again. And now I'm just basically going to walk up on one side. So within rectus abdominis,
You can palpate on a single side, or again, if you're wanting to, you can palpate on both sides. A nice easy way to do that, again, is just for a very slight crunch and engagement, and you'll be able to feel the edge of the rectal sheath, and you can relax back down again. So this is giving you an outline of rectus abdominis on one side versus if you were trying to palpate on both. Now, as a lot of you have seen, kind of that 6-pack or 8-pack, rectus abdominis is not just one tube of muscle, but it's actually more intermuscular segments. So you have connection pieces where there's little packets of muscle almost where they shorten together. So as a person again comes up for a slight crunch, good, you'll have these small sections all shortening together, keeping the muscle fairly flat, and you can relax. So again, bilateral palpation, rectus abdominis working its way up towards the rib attachment, and centrally it goes right up to the costal cartilage of rib number 7, which meets in the middle here at our xiphoid process, and just lateral to that on the costal cartilage of this 7th rib, the last one to go into the sternum. So that's heading down in this direction here, slightly above that on rib number 6 costal cartilage, and then rib number 5. So this muscle is going all the way up, right kind of where the bottom of pectoralis major is going to be attaching. So again, just a nice slight crunch, good, that's more than enough. So it's much wider up at the superior attachment, and it gets a lot narrower as it goes down towards the pubic attachment, and you can relax back down. So that's going to conclude our bilateral and single-sided palpation of rectus abdominis. This video is going to be for the palpation of the muscle known as subclavius. Subclavius means below clavicle. It's quite a small muscle, and we don't really talk too much about it in a lot of therapy. However, its job basically is to help stabilize this medial end of the clavicle and draw it inferiorly. So sometimes the individual is having difficulty lifting up that clavicle, or it rotating as you go through flexion, or they've had a trauma or injury to the sternoclavicular joint. Sometimes subclavius can be extremely tight. So what I'm going to do is show you the O and I and a little bit of palpation for it. Its origin is more central, which is on top of the costal cartilage of rib number 1. So this being the clavicle here, rolling off and underneath in this area. And its insertion is in the groove for subclavius, which is in the middle on the inferior surface of the clavicle, right as it transitions from convex into concave. So again, to try and get at that, you'd have to have the shoulder relaxed a little bit. So I'm going to lift up the shoulder slightly and tip my finger to the underside and push back. So this can be a little bit more of a sensitive area for this muscle. Again, it's not something that a lot of people have poked at, but our fiber direction is going to be running in this direction. So again, I'm going to suck up underneath that clavicle with the pads of my fingers as best I can, and try to do a little bit of palpation back and forth. At the same time, I'm going to ask him gently just to try and pull down his clavicle. Good. And relax. The majority of that's going to happen through pectoralis major. However, you may feel some tension or tightness, especially as you're trying to palpate this muscle all the way along this area. The other thing that you could do is try to bring the arm up through a little bit of flexion. We'll start to roll that clavicle posteriorly, and then you might be able to suck up underneath that a little bit. So I'm trying to squeeze my fingers to the undersurface. One more thing to note is how much mobility there is inside that clavicle. So using a pincher grip, if this clavicle isn't moving at all, or it's very, very restricted, there might be a lot of adhesions or tightness inside your subclavius. So again, trying to hook to the underside and doing some palpation might help create a little bit of mobility for this clavicle to move around. That's going to conclude our palpation of subclavius.